Welcome, everyone. And I'm going to invite you to sit down. Thank you, or at least move. How about that? Thank you. Welcome. I am Robin Axel Adams. I am the manager of the Fairbanks Center for Medical Ethics, and we are so glad that you are with us either in person or virtually. So no matter which way you're joining us, welcome. I will encourage you as soon as I click it to text this code. If you are in person and you signed in, you will receive your CEs and such. But if you are virtual, we ask you to text that to the code so that you can receive your CEs or CMEs for today's lecture. And certificates are being sent out approximately 30 days after today. Oh, everybody needs to text. Annie is whispering to me, everybody needs to text. I am so sorry. If you would like CEs or CMEs, everybody needs to text. So everybody jump on the texting bandwagon. All right, today the webinar is being recorded and is available on our website, fairbankscenter.org, within the next week. We encourage you to send your colleagues any of this information. The Q&A box is available for you to post your questions throughout. However, we won't be responding to most questions at the end of the presentation. And all presenters have no financial conflicts of interest to disclose. Today's presentation is such an exciting accumulation of all of the really hard work that has been done at Riley Hospital over the past, in a sense, centuries, but then lately in the last 5 to 7 years that has happened around the field of pediatrics and pediatric ethics here at Riley Hospital. And so I'm excited to be able to share our presenters who are just going to talk about the continued progress and the drive that they have for this program. And so we have 4 amazing speakers today, and I'm not going to be able to do the long introductions that they each deserve, but just know that they are amazing people and are doing amazing work. So I just want to share with you a little bit about who they are. So Dr. Brian Leland will be sharing with us, and he is an associate professor of pediatric critical care medicine and the director of the Fairbanks Center for Medical Ethics and the medical director for pediatric ethics at Riley. And Hannan is going to come and share, and she is the director of the Riley Cheer Guild and gift shops. Dr. Nayan, I practiced this, we'll get a running start. Nayan Srivastava, thank you, Nayan, and I apologize, who is joining us back at IU Health and Riley Hospital. She's a hospitalist with the pediatric critical care medicine, and all 3 of them are also past fellows. And then we have the wonderful Dr. Zeynep Salih, who is an associate professor and the director of the ethics curriculum in the neonatal perinatal fellowship program. She's the director of the ethics elective and case-based ethics curriculum in the pediatric residency program. And she is the division of neonatal perinatal medicine in the Department of Pediatrics. And so she wears many hats in the ways that she contributes to Riley Hospital. So it is my privilege, in whatever order they come, to share, for them to come and share with us. So thank you.
Thank you so much, Robin, for that wonderful introduction. It is a pleasure to see everyone again, and I am elated for the slide advancer not to be working. We're gonna try. Oh, okay, all right, wait.
Yeah, there we go.
See me learner information for anyone. Another disclosure summary. So it is my pleasure. I'm Brian Leland, by the way, director of the Fairbanks Center for Medical Ethics and the medical director here at Riley. My pleasure to be co-presenting today's lecture with our expanded team. I'm getting old, my glasses now officially have to be a part of every lecture. We have no disclosures, much to our disappointment. We look for them. Please see us afterwards if you're in a position to make that happen. Couple learning objectives for today. We are going to explore the history, growth, and nature of pediatric ethics consults here at Riley. We are going to go into detail about the pediatric unit-based ethics conversation program, as well as our pediatric ethics committee, which was recently founded. And we are going to walk through educational infrastructure and resources for ethics here at Riley as well. I would like to start, however, with slides that, if you were with me when I presented a year or 2 ago, were towards the end of the presentation, where we talked about growing a culture of ethics and the long journey that got us to where we were 2 years ago. And I told you that we had surveyed the landscape, that we had planted seeds and were maintaining fertile ground, and the next thing to do was to tend our seedlings, or to ingrain ethics into everyday workflow. I defined the goals for achieving that as followed. And I will tell you that I am excited to share that we have accomplished every one of these goals, which we'll get into as the presentation moves forward. So Robin very astutely introduced you to the other members of our now growing team, and I just want to highlight what a privilege it is to have them be a part of this growing ethics infrastructure. And since he is here today, I also want to make a point to acknowledge President Gil Perry, whose support for this growth has been instrumental in our ability to broaden the resources that we have available now. I also want to highlight what I think is the most wonderful dynamic of relationships between the ethics infrastructure niche here at Riley for pediatrics and our ability to leverage then even larger body of resources and personnel through the Fairbanks Center for Medical Ethics and the Department of Clinical and Organizational Ethics at IU Health. And one new person in particular that is the face you may not recognize before. This is Dr. Emily Holmes, who we had the privilege of welcoming as our new Associate Fellowship Director for the Clinical Ethics Fellowship over at FCME. So welcome to Dr. Holmes. All right, let's get into pediatric ethics consultation, which will be my portion of the presentation today. So ethics consultation is defined as a service provided by an individual or group to help patients, families, surrogates, healthcare providers, or other individuals or parties help them address uncertainty or conflict regarding value-laden issues in healthcare. This is how the American Society for Bioethics and Humanities defines this service. We are in a position to offer that service to you here at Riley and the larger academic health center. And I always want to make sure that you all know that we are available 24 hours a day, 7 days a week, 365 days a year, like any other consult service. We do not have banker's hours, and so please know that you can always engage us. We recently added a diagnosis room that you can broadcast into as a mechanism for a request for an ethics consultation, and that's under AHC Ethics Consult Room. You can see the number there where you can call directly to the on-call phone that is carried by whoever is in charge of consults during that time, or you can reach out to the operator and ask for the ethics consultation service. We honor a small team model, which means that we have a supervising consultant and then one or more sub-consultants. And then we leverage things like our Wednesday ethics consultation subcommittee meeting to present things at a larger group when there's a really complex issue. I will race through this because I talked about it in great detail 2 years ago, but the history of ethics infrastructure at Riley is a really interesting one to talk about its evolution. And most, as concisely as I can, there was essentially nothing but informal conversation about ethics prior to 1983 when federal legislation mandated that there be formed in all pediatric hospitals that were going to receive federal funding, something called an infant care review committee to process and navigate ethically complex challenges. And Dr. Schreiner at the time took that responsibility on. And then between 1983 and 2009, there were probably 4 different iterations of models for ethics consultation, between Riley designated individuals to a combination of the Fairbanks Center for Medical Ethics and Riley individuals to then in 2009, ultimately, those other models didn't prove to have staying power, and so FCME took over that responsibility fully. But the reality was that consult engagement was just stagnant. And so when I came on in 2016, I had the privilege and challenge of figuring out why that was and how to grow the consult service. And it became pretty apparent to me through a needs assessment that trust was what was missing. And that meant that Riley is unique. And I don't think that's news to anybody in this room, but in order to engage a service that is called upon at the most complex times in a patient's care or in a team's management of a patient's care, it was pretty clear that an appreciation for institutional memory, establishment of human relationships, and a designated pediatric expertise in the consultants was something that was valued. And I'm really excited about how effective honoring those specifics has allowed us to be. Hey, this shows up way better for you all than me. Great news. So this is our consult data summary sheet. So for every consult that we do at the Academic Health Center, we fill out one of these sheets, and it's an electronic PDF. And this is what allows us then to effectively evaluate our consultation metrics, which I'm excited to show you here. So This goes all the way back to 2008, which is when we began using our current recording system for ethics consultation. But as you can see, I think exponential is technically an inaccurate statement. I bet Dr. Rogerson would agree with that. Okay, but rapid growth. So if you look back, in the 2008 to 2014 range, really consults were kind of stuck in that 12 to 15 range. And then we exploded. And last year was our heaviest consult year ever with 43. And as of middle of September, we have 34 this year, so in good position to approach or even exceed that. And is Jane Hartsock in the room? Great, because she is annoyed about this, but I will proudly say that at least year to date, as far as I understand, Riley has requested more ethics consultations than the rest of the Academic Health Center. I think that's right, is it not, Kelsey? Okay, I'm gonna take that as a yes. All right, so what do our trends and metrics look like since the last time I gave you an update, which was a 2008 to 2018 timeframe for review. So from 2019 to current, which is when our consult numbers have really picked up, there have been some interesting similarities and a couple important differences that I want to speak to. So consistent with previous analysis, our patient age demographic is about the same, with patients under 1 being most represented in consult requests. And then patient location for consult requests continue to overwhelmingly be in our intensive care units, which makes perfect sense, right? The highest acuity and greatest level of complexity combined with the greatest sense of urgency and time not being a liberty tends to lend itself towards ethically challenging situations. I do want to highlight, however, that we've had steady growth in our outpatient consult request. And while I'm really excited about that, we'll talk about that as an opportunity for improvement. But this is out of an N of something like 160. So previously our outpatient consult represented something only like 3 to 4% of total consults. So making headway there for sure. Physicians continue to be the most common requesters for ethics consultation. I think I want to show a little equipoise in interpreting these results, because while the physician may be the one to formally make the consult request, I think there's every reason to believe, and in my experience, that request is instigated by other team members, even if they're not the ones to actually make the request. I will highlight our other category, which does include patient families, and we'll talk about why I brought that up here in just a minute. But ethics consultation service is a resource that is available to everyone, not just to members of the medical team. So we record what our ethics intervention is, and just so you know, you can mark more than one ethics intervention, which is why these numbers do not add up to 168. This is how I, inflate my numbers and make it look like we're making a lot of accomplishments here. But so making recommendations and providing moral support for the team are the two most common ethics interventions. And I will acknowledge the third there, which is values clarified. And I think that there is a growing appreciation for how values are imperative to inform a framework for decision-making and ethics consultation. So we also record something called the reason for consult, or the ethics issues that are identified in each case. And for reasons that I can't explain, I gave you the top 9 instead of the top 10. But our top 9 you can see here, which mirror in large part similarities to our previous analysis, but have important differences that I do want to bring up. So when we compare our analysis from our 2008 consult to 18, I apologize, our top 5 there compared to our top 5 ethics issues identified from 2019 to present, I want to bring your attention to numbers 4 and 5, where previously non-beneficial treatment, previously known as futility, and concerns about code status were the 4th and 5th most commonly identified ethics issues. And now they are surrogate decision-making and communication. And I would propose to you that, and I'm hopeful that that in fact is a reflection of a growing appreciation for ethical frameworks for decision-making here at Riley. And I will defend that by saying non-beneficial treatment and code status are the what, they are the thing, whereas surrogate decision-making and communication are the how, or the way to navigate a concern. And I'm really encouraged about that evolution, because I suspect that the exact same types of cases that the questions that are being, well, I know this because I do most of the consults, the types of questions that are being brought to us are so much better articulated now over the past couple of years, and that's reflected here in our ethical issues and reasons for consults. We also have incorporated a QR code survey system, as well as Mrs. Kelsey Miller sends out emails requesting feedback to anyone who is involved in an ethics consult. And because we're always looking for ways to improve or to assess our utility and our value. And I'm encouraged to share with you that overwhelmingly feedback is positive. This is from a previous quarter, speaking to overwhelming positive perception of accessibility, timeliness, and quality of both the content communicated as well as the relationship dynamic between consultants and the teams requesting consults. My favorite statistic here is what you see on the left, which says that 1 out of every 2 people that have filled out a survey that were involved in an ethics consult have never previously been involved. And to me, that is a wonderful thing, because it means that there are more and more people actively engaging ethics and are likely to do so in the future, based on the fact that 98% said they would request our participation again. I will bring your attention to comment 3 here, which I think is something that we pride ourselves on and are very intentional about, which is engaging every key stakeholder that is pertinent to an ethics case. And we take very seriously the responsibility of getting every perspective that could be helpful for informing a framework for decision-making as we navigate complex ethical issues in patient care. All right, so speaking of slides from last presentation, this one should look familiar. I had told you at the time that there had been what I thought was a misperception or miscommunication about ethics being colorblind as the approach to navigating DEI. And I had argued, in fact, that ethics is hypersensitive to color, and that it is our absolute responsibility to prioritize culture and socioeconomic status and race and ethnicity and religion and primary language, as well as values and preferences into the care that we're providing. So we put our money where our mouth is, and we formally looked at it. So we did a 13-year review comparing the pediatric consult population demographics to the general inpatient hospital population demographics to see if there were disparities in those demographics. And interestingly, we identified that African Americans and those with government insurance were overrepresented in our pediatric ethics consultation population. I want to say out loud that while we can absolutely identify this as a disparity, it is very complicated, and we're working through navigating whether this speaks to an inequity or rather is just an acknowledgement that while we appreciate protocolization and systemization, that engaging someone in the very intimate aspects of their lives and how that informs decision-making means that people are going to necessarily move through a process differently because of those preferences and values. So one of the things that we have done in response to this in order to better track this and try to inform future practice is added to our consult data summary sheet what we call PEARLs, but it's demographic information that is specific to payer source, race, religion, ethnicity, and primary language, so that we can continue to evaluate and ensure that ensure that disparities are not equating to inequities in the care that we're providing or how resource utilization is happening in ethics consultation requests. All right, my last slide, I think my 15 minutes is up. So what's next for us? And this will be talked about a little more in a couple areas, but say over and over that families are empowered to engage the ethics consultation service. And the only people that don't seem to know that are families, which defeats the purpose of us saying that that is something that they're empowered to do. And so we have prioritized taking that on to make sure families are aware of that resource. And then, as I mentioned, while we're really excited about the outpatient consult request growth, I will bring to your attention that the number of patients cared for at Riley Hospital on an outpatient basis each year is drastically higher than the number cared for in an inpatient setting. And as such, it's still underutilized, undoubtedly. So we're going to promote awareness there. We're also going to work to have members of the ethics consultation team physically present on rounds for subspecialty teams that will have us. And then lastly, as the maternity tower is up in full swing now, we have endeavored to foster relationships with them so that we can make sure that we are identified as a valuable resource as well in that area. I'm going to hand things over now to the lovely Ann Hannan, who's going to talk about her UBEC program.
Thank you. Ooh, my UBEC program is our program. Thank you, Brian. So I appreciate being invited to stand back up after I was invited to sit down because I was in the way earlier. So I appreciate being here. Just so you know, the information that Brian shared about institutional knowledge and relationships with people, I have been here at Riley for 23 years. I birthed a child in the OB ICU and lived with him on our neonatal intensive care unit. And so I absolutely 100% support that. And I'm excited because this particular arm of the Riley pediatric work is what is going to continue to foster that element of trust that Brian so eloquently described, not only anecdotally, but with all of his numbers, inflated or not. So what is a unit-based ethics conversation? It is a forum for staff to explore ethically challenging situations. And there are three areas that we hope to accomplish within that forum. And that is that we want to have a morally open space. We want people to come into that conversation knowing they will not be judged for whatever they bring forward, because ethics is emotionally charged, it's philosophically and theoretically charged. And so we want people to know that when you walk into this conversation, this is a space where you bring yourself and we talk about that. We want to increase the participants' abilities to deal with these ethically challenging situations and help them to examine the actual issues related to ethics that are embedded in patient care. So there has actually been a lot of research done grown right out of our own IU Health and Fairbanks Center for Medical Ethics. And what we have learned about the formal unit-based ethics conversation program is that there are three areas that can occur. You can attend a UBEC and you can be a receptive participant, meaning you just sit there and we anticipate that you will walk away with something, because we have learned that there's a learning benefit. It might be about ethics terms. It might be about what your resources are. There's absolutely a building of community, because as you step into a vulnerable space together, you create community. The psychological benefits, which is something that impacts every single aspect of the work that we do and the initiatives that we have across pediatrics, are far and wide. Some of them happen slowly and grow as individuals continue to engage in this type of service. But the bottom line is we want them to understand why they are feeling the way they are feeling when there are ethically challenging situations. We want them to understand if there are barriers to being the best advanced practice provider, physician, nurse, chaplain, child life specialist, how to identify those and how to understand what is within their own capacity to change. That is what we call moral agency. So this is something that we actually provide to our UBEC facilitators as we train them. So it might on the outside look like a chat. That facilitator's coming in, they're gonna sit and talk about all the things that are distressing team members on a unit. It is actually very intentionally held space. We come in with a judgment-free space with lots of background in ethics and a lot of background in the areas that we serve. And we create an opportunity for individuals to come as they are. There might be emotions, there might be withdrawal, there might be just a willingness to, we talk about verbal and emotional dump. And then we do something with that. And so we create the opportunity to help identify, these are emotions. What are they connected to? What is the ethical issue? What's it called? What is actually happening? Some of these are really big words that a lot of us as clinicians have never been introduced to. And knowledge is power. And often when we understand what is happening and why it doesn't feel good, that's when we feel that we can take a step forward. So our facilitators are specially trained to walk through this spiral as many times as they need, not to solve anything, because you cannot solve an ethical conflict. As Brian mentioned in the earlier part of this presentation, we make recommendations, we help to identify resources. There is not a solution that happens in a unit-based ethics conversation. There is the community, there is learning, and there's the psychological benefits that occur from coming together and having those conversations. So there is actually an imperative for us as institutions to provide specifically this type of support for our clinicians. And why is that? They need to discuss the ethical challenges, because the ethical challenges are what can impede excellent patient care. And that's what we're here to do. We're here to take care of our patients. This issue examines the theoretical and practical implications of moral distress and is a first step towards creating a climate in which professional integrity is not at odds with personal integrity. That's the values clarification. And so the background of training for our facilitators is back in 2005, they began at the Academic Health Center, and they were based on identified need for nurses to openly discuss ethical challenges. For those of you that have been here for a while, the instrumental individual was Dr. Lucia Woschel, nurse ethicist. I love that. It's got lots of shh in it. And she and Janina Miller, who is a nursing professional development person at West, have done a lot of research and work and have developed the body of supporting evidence for us to now provide this facilitator training. And so as we moved through that, training was officially began to be offered in 2012 and continues today. Now, one of the big questions is, do I need a UBEC or do I need an ethics consultation? They go hand in hand. Sometimes you can have one without the other, but often what will happen is if you get an ethics consultation, your consultant is going to identify if there is a high level of moral distress among the team. That can be addressed during or after that particular ethical conflict with a unit-based ethics conversation. There are also times during a unit-based ethics conversation where someone comes forward and the recognition is this is not solved, this is ongoing, whether it's a repeated issue that occurs throughout a patient population, and we need an ethics consultation so that we can work through this and create an environment that is successful for our patients. So the difference is the UBEC creates an open space for dialogue. The ethics consultation is an official review, interaction, and support from the ethics consultation team. Both are incredibly valuable. Both can go and complement each other, but they are separate things. So we are creating a culture here at Riley where team members know about both. And I will say another significant difference is that the unit-based ethics conversations are not an arena that is deemed appropriate for families and patients, whereas obviously our families and patients not only can request, but can also engage directly in the consult. This is something that takes care of our team members. And why do we do that? We do that because moral distress is something that is actually very unique. Oh, where's my slide about what it's not? So I'm sorry, I'm skipping ahead. I'll give you some data in a minute. So moral distress is the impediment of acting as a moral agent and doing the thing that you know you must do to protect your patient. Promote beneficence, prevent harm, make sure they have informed consent, and that they have the best possible outcome and experience while they're here at Riley. Each time there is a barrier to your moral agency, it creates what is called moral distress. Moral distress is different than grief. It is different than burnout. It is different than compassion fatigue. We experience all of those things in tandem, but moral distress is specifically related to an ethical issue. And what ends up happening is that each time you experience moral distress, it's like pouring oil in a pan and pouring that oil back out. You have to do something to get all of the oil out of that pan. You have to scrub it. You have to use a oil-based cleaner. And so it leaves a residue. And so each time you have another event and there hasn't been appropriate intervention, it will continue to compound. And then you have individuals that ultimately leave your organization, leave your profession, or leave to do something that does not put them as often into those ethically challenging situations. So, and I just said this, it's not burnout, it's not compassion fatigue, it is specifically unique and related to being in a hospital setting where individuals are making really challenging decisions about their own care, and in pediatrics, caregivers making decisions about their children's care. So I'm going to pop back over here and give you a little data. So it occurs when an individual's moral integrity is seriously compromised, either because they feel unable to act in accordance with core values and obligations, or their attempted actions have failed to achieve the desired outcome. A moral agent, which is what we hope to create with the unit-based ethics conversations, is an individual who makes a moral judgment based on commonly held notion of right and wrong, acts on that judgment, and is accountable to others for the actions that are taken. So in 2022, here are the pediatric unit-based ethics conversations that we held, and you'll see they were in labor and delivery, oncology, peds, HEMOC, PICU, and specifically with the RT team. And these are the ones that we have thus done in 2023. And I will say I'm incredibly proud of this 60 people attending February. That was an online hybrid that was all actually online. We do hybrid, we do in-person, and we do online only, and the entire division of oncology came. And so it was really phenomenal to know that that many people had the opportunity for psychological benefit, community benefit, and learning benefit. So we have far surpassed what we did back in 22. Thanks all in part, no, not in part, completely to the support that we have received for me to actually have dedicated time to do this as provided by Riley. So we are promoting moral agency and we're enhancing moral spaces. Here is a list of your currently trained UBEC facilitators here at Riley. We do up to, depending on schedules, 2 trainings a year. We also do an annual refresher with all past trained facilitators. They are across not only IU Health, they are also across the country. We have facilitators that have been trained in other areas or facilitators that have been trained as IU Health team members or partners and then moved to other areas. I would like to point out the diversity in this group. We have chaplains, social workers, individuals who are now in administration, nurses, advanced practice providers, music therapists, child life specialists, all different types of individuals working both in patient, outpatient that have, are new to their career and then also who are incredibly experienced and advanced in their career. So if you are a trained UBEC facilitator in this room, could you please raise your hand? Yeah, look at that. Look at that, pretty cool. So, all right. So we know there's lots of things that contribute to moral distress. And why is this significant? I've said this already, people leave. People are also experiencing secondary trauma as a result to organizational barriers, unit barriers, and ethical barriers to their care. And so how do we deal with this? We give all of these types of opportunities for individuals to educate themselves about ethics. From a unit-based perspective, this is what we're doing. We are intervening directly with unit-based ethics conversations and many other types of cool ideas that we have of how to connect directly with the people who are experiencing moral distress. And then as an organization, we are creating opportunities for IU Health to be healthier and for Riley Children's Health to be healthier. So the last thing I want to talk about very quickly, because you have educational information from Nayan and Zeynep that you are just on the edge of your seats to hear, is that starting in November of last year, Brian and I began meeting to develop a charter for and our inaugural pediatric ethics subcommittee. You are all invited, by the way, to attend and engage in any way that you would like. All you have to do is reach out to myself or Dr. Leland. If you reach out to Dr. Leland, he's going to forward you to me anyway. So feel free to reach out to me directly. So actually, Dr. Leland designed the majority of the charter, and I read it lots and lots and lots of times. We identified the initial potential members of individuals who have been engaged in ethics work in the pediatric area, and we had our very first meeting in February of 2023. Started out with Dr. Leland being the outgoing chair, me as the incoming chair, and Tracy Kaufman stepping forward as our secretary. We had our second one in May, and we developed a survey for all of those inaugural members, asking them what is important to you about ethics in pediatrics. We reviewed the results of that survey during that second meeting, and in August, we had a beautiful journal review opportunity where very robust conversation about what is unique about pediatrics and ethics. And then we created our priorities for this year. And based on that survey, here are our priorities. And Brian gave you a little commercial about this. We are committed to increasing the awareness of and access to ethics support in outpatient areas. The three people who stepped forward to pull together recommendations for the committee are Ashley Morlock, Melissa Young, and Allie Lee. They are going to be working together to make recommendations by November 1st, which we will review as a committee in December. The second one is increased access to pediatric ethics support for families, both inpatient and outpatient. Kelsey Miller, Beth DeHoff, and Zeynep Salih have stepped forward to lead that initiative and provide recommendations back. This is a working committee that is committed to making a difference as soon as we possibly can for everyone who is involved in ethics consultations. So thank you very much. Send me an email if you want to know more information about getting involved in any of these exciting direct connection with our staff and patients opportunities at Riley. And next, Nayan and Zeynep is coming first.
Great. So I'm gonna tell you about how yes, I'm sorry for my voice. I'm still jet lagged from a very long flight. So yes, my interest in medical ethics started when I started working in NICU, right, newborn intensive care unit. So then I met Dr. Paul Helft. I did a fellowship at Fairbanks Center for Bioethics, and then I did my master's, and I started a curriculum for our fellows in the newborn intensive care unit. Then I asked myself, how can I expand it to the pediatric residency program? So that time I met with Dr. Mary Ciccarelli. She was the vice chair for pediatric education at the time. So she said, why don't you start an ethics elective for the residents? So we started that. And I really love that because the teaching philosophy is creating a safe environment where the residents, can discuss cases and integrate knowledge into a helpful framework to approach ethical dilemmas in medicine. And I found out, and I totally believe that the best way to do it is meeting with the resident one-on-one, so that we can tailor the topics based on the residents' needs. So the first day I met with the resident, I start with the question of, tell me a case or cases that made you ask, was this the right thing to do? Or is this the right thing to do? So here's an example. We had a Med-Peds resident who had a case from the VA who did not get a life-saving surgery because the patient disagreed with rescinding the DNR order for the surgical procedure. So I had several meetings with the resident where he thoroughly reviewed the ethical principles of autonomy, beneficence, non-maleficence, and justice. He reviewed and discussed with me the DNR orders, the history, the rules for DNR orders for the OR, and physician's duty towards his or her patients, and physician-patient communication and relationship-based patient care and decision-making. So in the end, he was tasked with to write an essay about this case. First, he starts with putting down the ethical dilemmas and how to approach them by using the knowledge he had gathered. So in the end, he wrote a beautiful essay about why DNR orders should not be rescinded for surgical procedures in the OR. I'm sorry. So, so our residents also attend the Fairbanks Ethics Committee meetings and Fairbanks Ethics Fellowship lectures, thanks to the leadership of Fairbanks. And over the years, many other faculty joined the elective, Dr. Ott, Gunderman, Dr. Leland, Dr. Srivastava, Dr. O'Neill, Jane Hartstock, Melissa Young, and Amy Martin now joined the elective as faculty. Evaluations were positive. Requests over the years steadily increased from 2 to 13 residents per year. And producing scholarship, I'm sorry, is also a very important part of the elective, which I'm going to talk in the next slide. One of our residents started resident-led case-based ethics case discussions, which a manuscript now is in progress. They presented their cases at local and national conferences. And they actually published in Pediatrics and also a book review in Pediatric Ethoscope. So as I said, one of our MedPeace resident, Angela Quain, she was also a Morris Green Scholar. She found the ethics elective so helpful for her moral distress that she said that she wanted to expand it to the entire pediatric residency program. So she started a case discussion series where they identify the cases, the residents themselves identify the cases. They schedule a noon lecture time with the chiefs. Then they met with me several times to discuss the ethical issues and events and decisions and policies surrounding the case. And then we discussed the outcome of the case. Then the residents decided who to invite to the case discussion, which actually made it very interesting and unique because we not only had the faculty from various divisions, but we had DCS, nurses, legal and risk management and social worker coming to the case discussion and bringing their perspective and the knowledge as well. And the residents did the whole case discussion facilitation. So now we have more faculty involved, which makes that they are going to bring more expertise to the elective. And now residents have the chance, the opportunity to attend peace rounds in Peace ICU, Fetal Center consultations, ethics committee meetings at Eskenazi and at Fairbanks. And of course, we are going to continue producing scholarship and mentoring the residents in terms of producing scholarship. I think that's it. Thank you.
Thank you, Dr. Salih. So in continuing with our discussion about education, I'd like to share with you some of the updates regarding resident, fellow, and faculty education. The American Board of Pediatrics provides some guidance on focus areas. The training should include structured ethics curriculum for the residents. It should address ethical principles of medical practice. And increasingly, we're seeing a focus on including ethical aspects of physician relationships with respect to physician-patient relationships, physicians with other colleagues, and just generally the medical field with society at large. So here I've included on the left hand of your screen segments from that ABP content guideline. And our core ethics curriculum has always focused on the basic foundations of autonomy, beneficence, and what they kind of generally group as rights. And we cover that content in a general pediatric ethics 101 session. And focusing on some more pediatric specific content, such as surrogate decision-making and the concept of best interest. Issues related to end of life and futility come under the general category of critical care medical ethics. In neonatal medical ethics, we have maternal fetal conflicts and what they call the imperiled newborn infant, issues that might be related to ethical dilemmas that come up in the delivery room. And then issues such as confidentiality, informed consent, and assent naturally lend themselves to discussion of adolescent medical ethics. As I mentioned to you, we're seeing more focus on what's generally grouped under the category of professionalism and institutional ethics, kind of echoing the initiative of the relationship of the medical field with the society at large. And you'll see that across our curriculum as we focus with partners across campus in spirituality and global health, and then opportunities to see clinical ethics in action here at Riley. For fellows and faculties, we have several ongoing learning opportunities. As we already mentioned, we have the Riley Ethics Subcommittee, which is open to anybody. Our group has done faculty development workshops. Topics have included dispute resolution. We've had lunch and learns. We've done formal education, including our Grand Round series. And for anyone who's interested, I would like to mention the FCME Fellowship Program, which many of you are aware of. The applications for the next group of FCME Fellows will open in early 2024. And if you'd like more information about that, please contact the Fairbanks Center or send us an email. There's a specialized training pathway for chaplains, and you can contact the CPE info at IU Health for more information about that. And as we have had many fellows, including myself when I was a cardiology fellow, do the ethics fellowship concurrently, we're in the process of developing a 2-year program where a fellow can do the FCME program as a 2nd year and then continue to develop their foundation in ethics as a 3rd year. Okay, back to you.
Thank you so much, Nayan. I think this is literally the second to last slide. So I'm not an arborist, so I wasn't sure what the next step in tree growth after seedling was. So I put a young tree that still has lots of potential to grow into an adult and mature tree as where we currently are in our growing a culture of ethics here at Riley. I cannot speak to how proud I am of the progress that has been made, but that does not downplay the opportunity to continue to grow our resources and infrastructure here. I want to make sure we do acknowledge FCME and the Department of Clinical and Organizational Ethics, Vice President Amy Martin, Director Jane Hartsock, our manager Robin Axel Adams. I'm going to forget all of the respective titles of the remainder of our team over at FCME and Department of Clinical Ethics. Dr. Mara Nitu, our Chief Medical Officer, I mentioned Gil Perry, Elaine Cox, who really was a huge support at the very beginning of my career here. Janina Miller and Lucia Boschel, who were integral to the UBEC program, and then all of our Peds Ethics committee members. We would be pleased to take questions. Will you do us the favor of saying who the question is for so that that individual can come up to the podium? Thank you so much.
Also, if you have a question, please raise your hand and wait till you have a mic. So But yes, thank you. I saw somebody start to give a round of applause, so we can give her another round of applause. Thank you. I do have one question online before we get to people in the room. This is not directed at anybody in particular. Do you monitor trends in specific subject matter of consults as the social and political climates evolve? For example, has there been an increase in consults around issues of pregnancy termination in light of Dobbs or gender affirming care as we see an increase in restrictive legislation in that regard?
So yes, that has been something that has been specifically identified as a huge indicator of moral distress. And so we have started a series of unit-based ethics conversations for our gender health clinic. And then a good portion of my time is specifically directed to the maternity tower and working with those leaders to help identify how we can provide direct support, in addition to obviously having the consultation service available for those areas. So I'm not sure if that fully answered the question, but we definitely are seeing an increase in the requests for that level of support and are proactively reaching out to those areas to provide that support. And then I think Brian has some numbers because he's dancing over here.
Much to everyone's disappointment, I don't have actual numbers, but I do want to just speak to the really intentional efforts that IU Health made when legislation changed. And in fact, there is a designated rapid response team for abortion or pregnancy termination questions. And our ethics team is a designated member of that rapid response team. So we have ethics frameworks for decision-making to help navigate those acknowledging limitations of the legislation. Man, we're good.
Thank you for the presentation. Congratulations on this amazing work that continues to evolve every year. How do you work with community partners and other organizations who also have a passion for doing good?
So great question, Mr. President. And what I would say is that that's an area that we need to strengthen relationships and engagement. The Fairbanks Center for Medical Ethics and the Department of Clinical and Organizational Ethics actually shared a floor with community engagement, which I think they moved out, right? So now we no longer share a floor with them, which I think unfortunately was a lost opportunity for a really good relationship. But the Evans Center for Spirituality is in our same area, as is congregational, thank you, I was definitely not going to use the correct term, the Congregational Care Network. And I know that we are working intimately with Jay, who is in charge of that program, to do community engagement in respective faith organizations. But it is a slow moving process for sure, and an area where we need to reconsider additional priorities there.
I have another one online. Are there any studies of the ethical concerns in shortage of child psychiatrists, specifically in regards to the increase of children in need of mental health resources post-COVID-19?
Yeah, so the short and quick is, I do not know, I have not come across an ethics-specific article about that, but for sure there is a pretty robust body of literature that has been put in place over the past couple of years surrounding the COVID pandemic, highlighting the mental health crisis in particular for children and adolescents who were removed from the environment of the school setting, and the impact that that had on them, and an acknowledgement that we already had insufficient mental health care resources, and now the need has grown significantly, and we have not effectively adjusted the resource availability to honor that. And I don't want to pretend like that phenomenon is unique to children. I think there is equally a healthcare crisis for mental health in the adult population as well.
Can I ask a question to everybody? So as we discussed amongst us before, many deep ethical concerns arise from that people really, as Anne beautifully said, that the people feel there's a need to do something better, but it's not done, right? For example, the previous question said, why there is no adequate number of mental health providers for the children, or maybe, I can tell so many things that can happen in the NICU that can make the lives of the parents better, but it's not something I can change because this is an organizational level issue. So I was wondering how we as a whole group, right? The ethics here, the organizational people, how we can communicate those issues better and make a change, make a difference. What do you think, guys?
My thought is, I think your group has an opportunity to be a very important input. You are a tentacle of the organization. You're in every part of the organization, and will have a lens that many of us don't. And so just making sure that we hear from you the trends that you're hearing, and identifying where we as an organization can make a difference, not committing that we can make the changes immediately or at all. But if we don't hear from you, we definitely can't.
So question, and this is towards Anne, I suppose. You're welcome, Brian. For the UBEC trained providers, do you have a plan to ensure diversity for them so that they represent the demographics of the patients that they're serving and the providers that they're serving?
That is a great question. So there is definitely a diversity in where they work and the role that they serve within where they work. It is not a solicited training program at this time. It is an open training program. So my request would be, if you have a recommendation of how to make sure that that information gets to the right people so that they have the opportunity to participate and have their leadership support to participate, we would definitely like that input. It is posted in anywhere that ethics information is posted, but I am sure that we are missing huge demographics of individuals for that training. The other thing about that training is that while it is free to all IU Health team members, it is a commitment to 2 full days away from their normal schedule, and they do require support from their leader to do that. I know that that can be a barrier and a challenge. We move it around. We have it accessible on different days of the week and different opportunities. We are continuing to flex as a faculty who train to provide that opportunity. But if we are missing communication pathways for the invitation, and or if you have a recommendation for our UBEC faculty of who you would like to make sure is invited to train, we would very much appreciate that opportunity.
I think we have time for one more question.
Small question for Anne about UBEC. I noticed there was a label of standing or like responding to,
yep,
but it didn't seem any standing in the table.
So that has a lot to do with the fact that the standing UBECs that were created were done when we had a full-time nurse ethicist on board who was able to create opportunities for monthly or bi-monthly opportunities. We don't have the faculty to do that at this time and aren't sure if the new nurse ethicist will have the same background training and identified need to do that. What we are attempting to create is regular interventions through UBEC, and that's work that we are building on. So a snapshot of that is that I have direct contact with our labor and delivery staff to create those opportunities. We've tried a bunch of different opportunities, and we usually have 2 to 3 people attend, and it's not because there's no moral distress, it's because there's a barrier to attending. And then the other area that we're focusing on is the neonatal intensive care unit in the Simon Family Tower. They have a lot of support from their leadership, and we've done a lot of intervention there and are looking to have standing opportunities. But that's why you have the significant difference difference between 2022 and 2023. She exited the organization in December of last year, but thank you for asking.
Thank you so much. And one more plug for the UBEX. For those of you not at Riley and are interested in UBEX, please go ahead and send an email to that fcme@iuhealth.org account, and we can get you set up for whatever you need. Thank you so much again to our presenters, and we will see you all in November.
Yes, and then I have to raise.
Yes, let's go back to the first slide so that we have. Can you get us back to the first slide?
I gotcha.
There's probably a faster way to do it.
They put it in the chat too. So.
Okay, perfect.